Good evening, everyone, and welcome to this evening's meeting of the Health and Wellbeing Board Community Subgroup. I think, and Dagmar will correct me if I'm wrong, that this is the first of our extended meetings where we'll be focusing on the booster programme and also post-COVID syndrome, which you'll see on the agenda as well. So we'll just kick off with the agenda. And I think first we've got apologies for absence. We've had apologies given, I think, from Mark Krillman and from Kaz. I don't know whether we have any additional apologies for absence. Not that I can hear. So I'll just move on to the next item. Minutes of the previous meeting. Could I just check that everyone's comfortable that the minutes are a correct record, or if there are any points of clarification? Again, it looks agreed. Thank you. So moving on to the first main item on the agenda, which is an update on COVID-19, and first sort of sub-bullet under that is a situational assessment report. So I will pass over to Dagmar to pick up on that.
Thank you, and good evening, everybody. If I could have my first slide. I think Clarissa is ill. She sends her apologies. Just in case you haven't got that, but Barry is kindly doing the slides for me. So if you move us on, as usual, I will give you a bit of a snapshot of where we are with the pandemic, and it's probably fair to say we got a bit used to it. And so far the message has been, it's pretty steady. But actually, it's pretty steady at quite high levels. That is still a concern. And just to draw your attention, I quite like this table because it has all the essential information in one go. The R value is what we're keeping a very close eye. You will remember it got talked a lot about. It's how many cases a new case will infect. And if it's more than one, the pandemic or epidemic will grow, and if it's below 1, it will shrink. So all effort is to keep the R below 1, and it has been hovering and it has been nudging up. That's obviously not what we want, particularly in the autumn going to winter. Then, as always, we look not only at the total number of infections, but we look at who is it, and at the moment infections have been in young people. They're not vaccinated, so that is in a way congruent, but we also keep an eye on the over 60 rate, and you will see here that the arrow is now up. So we have some bleeding into older age ranges, and that again, if we start to think what is the impact or potential impact of the pandemic, is more of a worry sign, and trying to explain, not that we have the proof of the matter, but looking very closely who are the people who get infections. It has generally been the unvaccinated, but there is more increasing evidence that double vaccinated, particularly in the older age groups, are also now being reinfected. You will have heard about the reports of some waning of immunity, particularly for those who had the second dose over 6 months ago. And that obviously leads us into the discussion, which we will come to in a little bit, around what we do about it and the various elements of our vaccination program. I also point out we've got 100% Delta variant, so that's not a dramatic news. But you might have seen in the news some rumblings and bumblings about Delta Plus, a new Delta variant. So we are keeping closely in touch with what is now called the UK Health Security Agency, that has replaced Public Health England, and who again do the genomic sequencing and keeping an eye on variants. And yes, there are always mutations going on, and there is a mutation that some people call Delta plus or AY. I need to even check 4.2. They don't have very inspirational names. But at the moment, it is not even what we called in the past a variant under investigation or a variant of concern. So from that end, I think it looks pretty steady. And if you go right to the bottom of the table, this is where we measure the impact on our NHS. Unfortunately, we haven't got the latest data, but very importantly, hospitalizations, particularly in Southwest London, have been steady, but we also know that there is a lag period. And if we now see the over 60 infection rate increasing, there is a likelihood that that will tip over into increasing hospitalizations. If you move us on. I think this one is quite a visual one, comparing all the different local authority infection rates. And you can see how we have been sort of bumbling along, and there's a tendency now at the end of those graphs to go up. And it is very interesting that Kingston was really rushing up, and Richmond particularly because of the outbreaks in schools. So a lot of infections have happened, particularly in the, it is sort of the 10 to 19-year-olds. If you move us on. This is just, in a way, a repeat or a more detailed slide around the hospital impact. You will note that the shape of the slide has changed a little bit because some of our data sources have changed. If you move us on. This is important, particularly for us as the health and wellbeing subgroup, particularly looking at equity. So we're monitoring what's the impact in the east and west of the borough with regards to ethnic minorities, age groups, and location. You can see that east-west, the two graphs, the yellow and the blue, they're crossing over. So I would say there isn't much of a difference at the moment, no strong signal. If anything, at the moment, the West is leading, and we can see that in terms of the school outbreaks as well. And then on the right-hand side, you can clearly see the youngsters are in the leading the infection rates. If you move us on. Very important for all of you as well to always be the sort of promoters. We still have free lateral flow testing, community testing, and trying to promote the uptake. If I just draw your attention, we had 670 positive tests altogether. So nearly sort of 78% were PCR, but that leaves 21% of LFT. So not insignificant numbers of positive cases found with an LFT. We can assume that those were asymptomatic. Well, we are not 100% sure, but LFTs are meant to be used for asymptomatic testing. So it shows you it contributes to our infection prevention control, the use of LFTs. They are still free. They're widely available to collect, to order, and also to do them in a supervised setting. If you move us on. These are our death rates. Luckily, fatalities have been low and steady. So there is still, we're talking about immunity of vaccine possibly waning in terms of infections, but serious disease and in particular fatalities, vaccination seems to protect and continues to protect. If you move us on. Now, this is a particular focus, obviously, of our subgroup. It's vaccination uptake, and particularly looking at groups that haven't had the high uptake, and are we making any progress? So the chart shows you overall vaccination by the different age groups. And on the right-hand side, you do see quite stark differentials. And hopefully we'll spend a little bit of time talking around the younger people's vaccination programs, because if you look particularly at the 16-year-olds, for example, there's a clear lagging behind. Generally, the uptake isn't as great as in the older age groups. Colours are much lighter, and then you can see a very clear east-west divide. So that is a important reminder for all of us to get our brains yet together into gear to think, what else can we do to engage with this particular cohort with regards to uptake. And then if you move us on, there's one more slide. Barry, I think it got stuck. This one. Oh no, this one was the last one. Sorry, I was checking. Was there one more slide with ethnicity? Barry? Maybe one has dropped out. So when we look at uptake by ethnicity, we also, despite really quite big efforts, don't see a lot of catch-up in terms of some of our ethnic groups lagging behind. And again, as a subgroup, and together with our NHS colleagues, rethinking how we can continue working with communities that have got continuing lower uptake. And it is particularly important because the vaccination program now is not as straightforward anymore as it was when we started. You know, it was get vaccinated. Now the vaccination program has different components, what they call the evergreen offer for those who still haven't had one or two. Then the booster for those 6 months after their second in the JCVI groups 1 to 9. Then we have got the 16, 17-year-olds. Then we have now the school offer of the 12 to 15-year-olds. And then we are very much promoting the flu vaccination as well. So it can start to make you a bit dizzy, these different components, and how we can still clearly promote, communicate, engage with our community to get uptake. And I haven't got data yet for the 12 to 15-year-olds. It is anecdotal, but it's coming. We've only recently started, 11th of October. I think we started our first school vaccination, but you will have seen and heard elsewhere in London and indeed elsewhere in the country, the uptake has not been particularly good, under 40%. So the NHS is changing now, and it's just being finalised that the vaccination offer will be beyond the school offer, to have the supplementary offer with very much fewer barriers, so that the youngsters can access through mass vaccination sites. We're just waiting to finalise the comms on that. And then there's also anecdotal evidence that people do not run in the vaccination centres for their boosters. But again, if I stress it is anecdotal, we need to really gather our data to then be very data-driven in terms of our promotion. So what we are working on behind the scenes is to rethink how we can report the progress in vaccination with the different elements of the program now in a more detailed way for the next subgroup, because hopefully by the next subgroup meeting we've got some data. I'm sure I will stop here, and I'm sure that my NHS colleagues have things to say and chip in. I see Sai, for example, obviously our primary care colleagues deeply involved and busy with vaccination.
Thank you, Dagmar. Sai or Vasa, did you want to come in on the vaccine progress to date?
I mean, what I would say is that the team have been working really, really hard. It's been a long year, hasn't it? I think for the vaccination team, is what I would say. What started off last year, I don't think we could have anticipated how long it has gone on for. But really, all I can say is that I really applaud the team and all their hard work and all the work they've done with the community as well. It's been fantastic, I think.
Great. Did we have any questions for Dagmar or I can see Una and Ellie.
Thank you. Firstly, yes, I'd just like to add my thanks and perhaps the thanks of this panel for all the hard work in doing the vaccination program, but also the testing program, which has been really big too. And on that topic of the testing, someone was asking me about the fact that in Europe, they're not testing. Well, I don't know. I mean, I think they said overseas. They're not testing in schools as much. So therefore, our figures, effectively what they're trying to say is that our figures look higher in London and the UK because we're testing more. And so therefore, the rates, particularly with the younger cohorts, are up. And so therefore, our rates are up. And I don't know how much that's up, but I mean, certainly around and about, there's a lot of people now not wearing masks, sort of generally feeling that it's fine to go back to normal in inverted commas. And it's actually quite hard putting the other side and trying to explain to people that actually these figures are, you know, as you were just saying, Dagmar, our figures are not looking good, and we're actually quite high for where we should be in the autumn. And yes, we should be worried about our figures, whether it's younger cohorts or in a sense, because they will bleed through, as we know. You know, if a youngster comes home infected, chances are that the rest of the household are likely to be infected, and inevitably, therefore, some older generation, and so on. So I don't know if there's any sort of comment there, but we do seem to be sort of measured against other countries and so on. So yeah, thank you.
If I chip in briefly, Una, to be honest, I haven't got the comparison up my sleeve around testing rate, positivity rates, and you know, the impact on hospitals in terms of Europe. I'm obviously aware about the discussions, and what I'm taking from it is that there might be a factor, but I don't think we can explain away our infection rates. I think the really important bit is that we keep an eye on where we are, with a particular focus on the impact and the harm. And therefore, you know, people who have had COVID again as well, vaccinated people, it's actually a nasty illness. Yeah. And it knocks them out, and it takes them out of work, and so it is to be reckoned with properly. And so in planning how we manage particularly the challenge through autumn and winter, I would say precautionary principle is a sensible way to look at it, and be prepared. I mean, that it could go either way.
Just one other question on the topic of testing. Are you aware whether there will be taking away some of the free testing that's being provided at the moment. I actually have written through, both in my capacity as a member of the Health and Wellbeing Board, but also a local verger. And because I strongly think that irrespective of schools and so on, where obviously it's important, the ability to be able to take a free test is very important for all of us, really. So, and I see that as a major plank in protection and breaking transmission and so on. I just wondered if you'd heard anything.
Yeah, so completely agree. It is one of our important tools, and I don't want that undermined at all. I think really important to distinguish PCR and LFT. So there's at the moment no discussion around charging for PCR. And with regards to LFT, we have had the assurance from the Department of Health that the community testing program and the free provision of LFT through the community testing program is continuing at least until December with another review there, but most likely until March with another review. So what I'm at the moment, in a way, planning, common things are common, that for the time being, we're promoting the LFT use and really try to establish routines, and particularly, again, make the offer available for people who need it most.
Okay, thank you.
Thank you, Dagmar. I also saw Ellie wanted to speak.
Thank you. And yeah, thanks for all the work about everything that's going on. But I want to ask about the schools and the secondary school vaccinations, and I suppose to kind of pause and unpick why we think there's low uptake. I know that schools have been put in a tricky position, and most schools are seeing it kind of not as their role to push it, but just as kind of to facilitate. But I just want to know if there's anything that we've picked up about the reasons for the low uptake that will be informing health partners on the messaging of the additional half-term vaccination centre availability. Thank you.
I think, Ellie, really good points, and I think we're all putting our thinking caps on. Share the learning, share across. Are there any schools where they have had higher uptake? What was that magic ingredient that they had and we didn't have? We haven't come across, you know, one overarching silver bullet. It is multifactorial, but the general principles that we've learned so well from the vaccination program with other cohorts is you must listen, you must tune in, and really lower barriers of access as well. So therefore, the idea that one day in a school, or possibly two, that's it, is just too restrictive. Because you have observed as well, and we've observed not just locally, but across London and the country, that around that consent form, it is very legitimate that parents take it seriously. This is not a completely easy decision. And so there is some yo-yoing as well. So people who have given consent then get a little panic at the last minute and withdraw it, or they sit on this consent form because they really don't quite know and need to talk it through again. So we haven't quite got that right to say you have to have one day, and that's your chance. So I'm very encouraged in a way that there is some catch-up learning quickly now to say we have to have a multiple access strategy, like we've learned honestly with the vaccination right at the beginning. Remember, you had to book and you had that appointment or else, and then we ended up you can walk in anywhere. Yeah, so I think we are fast tracking that learning again with the youngsters. But I also have to say, people have been brilliant, schools have been fantastic, head teachers have been really trying to support. Yes, it is an NHS initiative, but I would say they have really engaged, and so I have got good vibes to say with a second push we will get it up a bit more.
Can I come back to you, Chair? It's just, I mean, to ask a separate point, which is, you know, we were originally aiming to try and get people vaccinated by October, which even in my view is too late. I think we could have made the decision earlier, and I think that could have helped with the messaging as well, because I think parents have heard some of the yo-yoing on the messaging, and so they're concerned. But we're not going to have them all done by half term. Some of them are going over to November. How worried should we be about that?
Well, to be honest, we are where we are. So for me, I can understand that with hindsight, etc., there might have been decisions out of our hands as well that left us in a position that is not possibly the optimal position. But I, in a way, want to use my energy to say, harping back doesn't get me anywhere. What can I do now with where I am? And that's why I'm looking to all of you as well, because I don't think we now need to say, we missed the train and that's it. We can still really mobilize. Yes, we might be a little bit later than we had wished, but by no means, I would say the train isn't quite left the station yet.
Thank you, Dagmar. Vassar, did you want to come in?
Yeah, and I think thanks. I think, yeah, we must keep going on this very softly, because from my point of view, from a child at school point of view, getting the vaccine is not the primary issue from a child's point of view at this point in time. There are a lot of other burning issues. From the country's point of view, it's a different story. And I think we mustn't lose sight of the child and the child's primary issues with education and mental health and other social issues, which are also quite pressing. And therefore, we must understand, where does this fit in the mothers or fathers' mindset as a whole. And as an NHS, we want to work with the child throughout the child's life. We're talking about healthy living and weight and diabetes and heart disease and smoking and drugs and alcohol and everything under the sun I want to preach about. So we really have to walk this fine line softly with the parent and the children. Of course, I got ulterior motive. I like to keep the bed occupancy of COVID in a hospital less than 10% throughout winter, because I need to create the space for the cancers and the hearts and the influenzas, which will come in to occupy some beds. So if the bed occupancy goes more than 10%, then there'll be a hit on somebody else's care. So yeah, I got an ulterior motive in this, but I got to balance that, the child's freedom to choose or the parents to freeze. And we walked gently along. And sometimes a bad cold spell changes people's mindset, because it's really the fault of science. We have taken away the burning platform. We have moved from a bad pandemic and nasty cruel virus to a virus which most people who get to hospital now leave the hospital alive and reasonably well. That was not the story in March or April last year. Case fatality for admissions was very high. Now it's actually low. It's around about 5% once you get in. Only about 5% sadly succumb to the disease. So it's a really, really different narrative. And in this background, it's a different place compared to where I was mentally myself in December after Christmas this year and where I am now. So that translates into the way I talk to people as well. And you can imagine, from a parent's point of view, in an endemic disease, why do I want my child to be vaccinated? And that's the dialogue I have, saying, yeah, you do get breakthrough and you want to see granted for Christmas, you might as well get vaccinated, because that matters to you, not Vassar and his bed occupancy. What matters to you is seeing granted for Christmas, and getting this is your passport to see granddad and not harm him. That's the narrative. So you choose the narrative for the patient, for the person, sorry, not patient, for the person, and we try and convince people, but gently, because we know the gentle persuasion has worked. Look at the care home narrative. Gentle persuasion has helped with care homes, not me pontificating about science. So I think that's the lesson, as Dagmar keeps saying to us. Just talk to people, listen to them, hear them, understand them, and gently take them on the journey, because their speed of travel is different to all ours. This is a very biased group. You chair, Rebecca. This group is committed to masking and vaccination and isolation and testing and tracing, because Dagmar has brought us all to order, but society is different to us, and we mustn't drift as a health and well-being board, we mustn't drift too far away from mainstream Britain, because there is a risk that we, out of our enthusiasm, will leave mainstream Britain behind. Mainstream Britain is in a totally different place to any one of us on this forum.
Very good point. Thank you, Vasa. Were there any other questions for Dagmar before we move on? I have one question, and that's just about the process for getting the third booster vaccine for those who are eligible. I'm sure other colleagues have also been contacted by residents who might be a bit anxious knowing that they would be eligible but maybe haven't been reached out to yet. And I just wondered whether we could set out what that looks like in order to get that booster jab.
I think it's a really good point, and I if I may pass on to my NHS colleagues, I think the message at the moment that we're giving is that you get called, so you don't just pitch up, and we don't want everybody to ring up and say, listen, why haven't I heard? But Sai or Vasa, could you help? And maybe there is a comms piece that we could strengthen Poricus on the call as well.
Yeah, so Rebecca, it is being centrally coordinated. So our service is on the national booking system. So really, we're happy to work around how we get the comms out around that so people understand what the process is. We appreciate there's lots of anxieties around it about when they're going to be called. So that's totally understandable, but we're happy to work with you around the comms on that.
Great, thank you. We can probably pick that up offline as well, make sure that we can get some comms out around that. Lovely. Were there any final questions before we move on? I can't see any hands. So thank you, Dagmar, for presenting the report. And now we move to actually the last item, which is on post-COVID syndrome. And I know there's been a lot of conversation about post-COVID syndrome or long COVID and the like, and there's possibly a lot of confusion or complexity around it and what the services are in the borough. So I know that Barry and partners are going to be presenting a report on this. So I will hand over to Barry just to kick off.
Thank you, Rebecca, and delighted that the subgroup have agreed to have that focus on post-COVID syndrome, both to keep an eye on the emerging impact of COVID over that longer term, but also to hold that equity lens at how we identify and support those residents that are most in need of our support. For our first meeting of 3, focusing on post-COVID syndrome, our purpose this evening is to raise awareness and the understanding of some of the terminology, the symptoms, and we'll touch on the estimated prevalence. Delighted that we've got a number of clinical colleagues to answer those clinical questions, which is fabulous. We're also going to hear from our colleagues in CLCH about the service offer and around who has accessed that service so far, bearing in mind it's a very early days for that service, but they're doing a good job. Then we're going to really hear about lived experience and the impact on individuals, families and carers, and then we can get on to a discussion on how best to support access to the right services for those most in need. Firstly, thank you to our Public Health England colleagues who have let me use their fabulous infographics this evening. And important to say that, as we know, most people who catch COVID-19 will get better quickly and they will not become severely ill. But those clinical definitions are really important for us. And so the signs and symptoms of COVID-19 for up to 4 weeks, we're referring to acute COVID-19. Then when we talk about signs and symptoms of COVID between 4 and 12 weeks, the terminology, the definition that we are using is ongoing symptomatic COVID-19. And then finally, signs and symptoms that continue for more than 12 weeks, which are not explained by an alternative diagnosis. And that's where we're using that definition of post-COVID-19 syndrome, so post-COVID syndrome. We know that there are a number of symptoms, over 200 that have been recorded, many overlapping, and there are clustering of those symptoms, and post-COVID syndrome can affect any system within the body. ONS reported in August that the most common symptoms that people are reporting are fatigue, shortness of breath, muscle aches, and that loss of smell. And when we talk about the main factors that make it more likely to suffer from post-COVID syndrome, again, we've got the information on the slides there about those factors around smoking status, those biological factors that we cannot change, so increasing age, being from the white ethnic group, being female, and then thinking about the wider demographics around areas of living in an area of deprivation, being a frontline health and care worker, and that underlying health conditions, asthma, having a disability, being hospitalized for COVID-19, being overweight or obese, and having that a mental health and illness. But we really do need to consider the impact of post-COVID syndrome, and we need to think wider than just that health impact, although that is absolutely critical to us. We do know that, again, adults are reporting a wider impact on their employment status, relationships and family life being affected by post-COVID syndrome and those symptoms that we've heard about. And really importantly, you can see there 10% COVID-19 has had an impact on their caring responsibilities, whether that's for younger people or older people within the borough. And so again, when we get onto a little bit later in that discussion, thinking about how we can come together as a system, as a borough, to deliver that holistic support to those individuals where they need it. Final slide from me, a brief overview of post-COVID syndrome, is around the estimate of prevalence. And it's fair to say there are a number of methodologies to look at to estimate prevalence. So what you're seeing in front of you this evening, colleagues, is based on the ONS. And this is based on the coronavirus infection survey. So this is self-reported, and it uses the total population as the denominator. And we're really presenting these numbers, and you can see the broad confidence intervals there, so that we can really understand the estimated population need to inform our service planning, the delivery, and really importantly, again, thinking the equity lens through those pathways. So the estimates you can see, all people, around 2,700 people within Merton could be affected by post-COVID syndrome. So that's 12 weeks they have these symptoms for. You can see higher within that 35 to 69 category, and higher estimates within women, which reflects the findings from the Public Health England. And again, thinking about that equity lens, we need to consider who is or who isn't presenting, and what we can do to refine our approach to case finding. So that's the kind of the overview as a starting point. And now I'm going to hand over to Campbell Flack from CLCH to give an overview of the service that we have in place, initial service data, and then really importantly, as we've kind of touched on, to hear that patient voice, that patient perspective. And both Campbell is going to give us an overview of that. I'm delighted to then ask Beck Youssef from Merton Health Watch to contribute too. So I'll hand over to Campbell, and Campbell, just let me know when you need to go to the next slide.
Okay, thanks, Barry. Yeah, so hi, I'm Campbell Flack, the clinical lead for Merton and Wandsworth Post-COVID Assessment Services. Next slide, please. So regarding our service, so we obviously accept any referrals for patients who have had symptoms beyond 4 weeks, and that's for confirmed or suspected COVID-19 infection. So we don't need necessarily a positive test for referral. We do need a range of pre-referral investigations to be completed prior to referral onto our service. Obviously keeping in mind that post-COVID syndrome is a diagnosis of exclusion, and we want to rule out any alternate cause for these people's symptoms. We are a predominantly virtual service, and it's therapy-led rehabilitation service with medical oversight, which is probably a bit of a paradigm shift away from other services where it's typically medical-led. We feel that it's best to be therapy-led for these services after they've had that review within primary care, and that we can provide them with all of that adequate advice, education and rehabilitation to improve their symptoms. We do offer face-to-face assessments for patients who can't access the virtual setting, just for equity of access. And again, the main focus of our service is to really promote self-management of individual symptoms through education and rehabilitation. Next slide, please. So we've had 145 referrals from Merton into our service to date. 74 are ongoing, 10 have been discharged due to resolution of their symptoms, and 61 had to be sent back to primary care just for some further investigation to be completed, but they may have been referred back to us. There's also a small percentage of referrals for our Merton patients that might be going to a couple of the other post-COVID services within Southwest London at the moment. And our referrals are up there with the highest within Southwest London. Next slide, please. So just looking at our demographics so far of the referrals we've received, so 77% females, the average age being 48 years, levels 1 and 2 of deprivation, so there's higher people from higher or more deprived regions is only 0.01%, so we know that does have to be a real target for us moving forward, given that level of deprivation is a risk factor for developing post-COVID. And then from ethnicity perspective, 40% white individuals, 20% from mixed ethnic groups, 16% from Asian or Asian British, 11% from Black British, Caribbean or African ethnicity, and 6% weren't recorded. Next slide, please. So this is just a summary of the symptoms based on the initial referral from the GP. So matching kind of ONS data, fatigue and breathlessness are the key symptoms we see. But again, you can see that there's a variable amount of symptoms, and most people are presenting with a wide array of those symptoms. We probably find that once we do an initial assessment of patients that they have more symptoms than reported on that initial referral. And my feeling is that primary care are just reporting the predominant symptoms that a person is suffering with at the time, or that's what the patient is reporting to their GP. We also know that psychological symptoms are probably underreported on the referrals, but a lot of our patients are struggling with their mental health and a deterioration in their mental health since developing long COVID. And that loss of taste and smell obviously doesn't match that ONS data for us, referrals into us. I think it's being managed within primary care or via the absence of dissent websites that are out there, or from referrals to ENT. Next slide, please. This is just a basic quick overview of our pathway. I'll go through it really quickly. But once the patients are accepted into our service, they're signed up with the Living with COVID app developed from UCLH, just because it provides a really good education resource for the patients, but also helps us to manage and the patient to monitor and manage their symptoms. We have a weekly medical MDT, a weekly mental wellbeing MDT with Merton Uplift, as well as weekly MDTs with our social work colleagues, and then with the specialist post-COVID assessment service that sits within St George's Hospital. Once they come in and are assessed by therapy, they'll go into various rehabilitation pathways depending on their symptoms. Next slide, please. Our primary interventions for a lot of patients are around activity planning, looking at their sleep and improving sleep hygiene, improving diet, exercise and physical activity levels, and helping them monitor and pace with regard to that. Planning and prioritising of tasks, return to work advice, which is a huge issue for a lot of individuals, relaxation techniques, looking at their breathing and then doing breathing pattern retraining or specific breathing exercises, and then providing positions to help manage their breathlessness. Next slide, please. This was just some data from the NICE guidelines and British Thoracic Society. I would definitely caution this when giving people education on when their symptoms are likely to improve. This is probably quite gross time frames. And a lot of the patients that refer into our service have obviously had symptoms from the start of last year or quite early on last year. It probably rings true with fatigue. Tends to be the most predominant symptom that's long lasting. So a lot of our patients will say that fatigue is their main issue now, and that's why they've come to see us. But initially they did have, chest pains or muscle aches or breathlessness. So that is probably why I suspect that is the predominant symptom that's reported for long COVID patients. After 6 months, there isn't much data around how quickly people will improve and what that trajectory is of improvement. But I guess the main thing to note is that once people are coming into our service, even if they're individuals who haven't improved or their symptoms have stagnated for the past 12 months, when we've been able to give them some education and advice, then 95% of our patients, I would say today, have their symptoms and then started to improve, which is really promising. Next slide, please. So just to have a really quick perspective of a patient that came through our service. So this was an individual who developed or had symptoms of COVID in March 2020, but testing wasn't available at that stage. She was referred into our service really early on in our development in June 2021, and her primary symptoms were fatigue and brain fog. With regard to the referral process, she did note that it was quite a long process, and she recognised that the tests were necessary, but they were also quite tiring to complete for her. She stated that it was definitely needed in terms of the testing, but it was an investment with my dwindled sources of energy. But she did state that once contact was made with the service, then she found the process a lot more seamless and felt that we were quite responsive. With regard to her symptoms, she reported something which we probably get globally with all of our patients reporting of those feelings of what is wrong with me? Am I really ill? Will I even get better? And those feelings are really common. And I think reassurance is probably one of the most powerful things that we do within the post-COVID service, but probably within primary care as well, reassuring people that the symptoms are real, they are quite common, they're really common with this long COVID population, and that there is rehabilitation techniques and advice out there to help improve their symptoms. She stated that for me, it's the fatigue, and that she feels that when she goes to sleep, she'll wake up and she's just as exhausted. So it's that, non-restorative sleep for her that is the big issue. She stated that her symptoms have gone from about 15 to 20 different symptoms to 7 or less, and she's had much less fatigue and brain fog since commencing with the service. Again, really common for people that get referred to us to have, an extensive amount of symptoms in terms of headaches, brain fog, fatigue, breathlessness, chest pain, deterioration in their mental health, hair loss, a really wide range of symptoms. Again, we can really help to manage some of those symptoms. In terms of the impact of the service on her quality of life, she felt from a medical impact in terms of the support, recovery and rehabilitation was really important for her. Psychologically, it was really important to have that acknowledgement and reassurance from therapists. And socially, she felt it has really helped her relationship with the people around her. She found the video consultations really important for her and really beneficial. She felt it gave her the human connection of having a therapist face-to-face without that physical aspect of having to attend a clinic, which obviously for her was really important, giving her significant fatigue. And she also reports that shared decision making was really important for her around goal setting. And she felt that we've had really respectful interactions, which was really needed for her. Her suggestions for improvement going forward are around the initial referral process and improving individuals' expectations and knowledge of the service and the service provision. And certainly, we've tried to focus on that and improving comms and increasing comms to primary care and other groups within the community to improve that expectations, both within primary care but for our patients. And lastly, in summary, she just found that from the first appointment, she was really happily surprised with the advice that she was given. She's had some really noticeable improvements, was given realistic support. She wasn't expected to suddenly get better, and that overall the service has made a really big difference for her. So we're hoping that that will continue with all of our other patients, and that we can continue to make a difference for those patients. In the extended slide pack that you'll get after the presentation, it has her direct points, but that was just a summary. And that's all for me.
Thank you, Campbell. I'm going to go straight on to our next, our second special guest, who is Beck Youssef from Merton Health Watch.
Good evening, everyone. Thanks for asking us to come along to today's session. I think there is no slides, Barry, is there? It's just me having a quick chat. Is that right? I just want to recap.
That's right, Beck.
Yeah, brilliant. So Health Watch Merton, together with other Health Watches across South West London, we put together back in July, August, a long COVID post-19 syndrome survey that was developed by the 6 boroughs. And has gone to date, we've probably gathered around, including ourselves, around 200 insights from people. And actually, interesting enough, listening to the presentations this evening, they are very much, the themes coming back from people are very much in line with what Barry presented on the ONS and what Callum's just presented now. So, for example, fatigue, when asking people about symptoms, the kind of prevalent symptoms from severe to moderate to mild, fatigue is registering as the top symptom across the areas. I mean, Wandsworth and Richmond have actually shared some of their findings as well. And anxiety too. Anxiety seems to be one of those symptoms, which I suppose, alongside all the other symptoms people may be experiencing, is potentially a natural consequence of living with long COVID. In Merton, to date, we have received around 11 responses, but actually based on 11 responses, there is still valuable data, which combined with the 200 plus received from South West London, it obviously adds a real weight behind a patient's voice in respect of what are the range of symptoms they've been experiencing, how has it impacted on the quality of life, and what support is out there that people have been accessing or feel they can access. So just to kind of go back, as one of the kind of makeup of the people that we've had so far in respect of those that have responded, again, very similar with the ONS stats. The higher proportion in regards to ages between 45 and 59. We've had 60% of female respondees to the actual survey. And again, around 50% of white British. Actually, looking at Richmond and Wandsworth's data, that is again in line with the response they've been receiving. And in regards to mental health, no surprise in respect of it has had a negative impact on people's mental well-being. And just in Merton, 10 out of the 11 people did actually respond saying it has had a negative impact on their mental health. So that again is comparable to the other, for example, Richmond and Wandsworth in the similar kind of regions. Interesting enough, like just going on in regards to support received, out of those that have responded, there's been 4 that have actually received an official diagnosis and 2 have actually received some form of support. When we kind of focus on the quality of life, very much again in sync with what was discussed earlier, it has had an impact on work, on livelihoods, relationships, concentration, which obviously we've been talking about, brain fog, and home life and some of those practical tasks. They seem to be the main themes that are coming through. in regards to the support that is out there, interesting enough, there wasn't as much support that was shared. The only support, and I think it was flagged up just now in the presentation, somebody received an inhaler and somebody actually saw a consultant about their enlarged tonsils. That is literally the only report we've had back. But I suppose as those opportunities arise, as this new service evolves, then hopefully people, if asked again, will have some more feedback in regards to the support. There is obviously some self-help group opportunities, and in respect of mental wellbeing, there are other potential pathways people can also access or connect with, for example, social prescribing, and there are actually some other groups running some online or other courses linked to specific symptoms. So for example, there is a charity called the Voice of Hope, and they do a 6-week course around breathing, and actually links with other respiratory illnesses as another alternative from the kind of medical route. I would say, just to give a quick sort of overview from somebody, just to read very briefly how it has impacted on them. They're a 32-year-old administrator finding it very difficult to do a full day's work. Home life has become difficult. They feel tired. It's a strain on their relationships. The usual things like going for long walks, carrying heavy shopping. This is affecting my mental health and well-being. And actually somebody just turned around and did say, I'd rather not be asked about the experience of long COVID. I just rather this experience ended so I can have some kind of life. And I think it kind of brings it all together. In respect to long COVID, we do talk about from the avenue, from the lens of the potential medical implications and some of those consequences and factors. But as we all know, there is the indirect impact on long COVID. When we talk about people's, they lose their work, for example, bereavement from losing somebody who did pass away with long COVID, or actually their roles change. All of a sudden, they're now a carer, where they're actually on a different path, where they were studying, or they're actually looking to move away, or in regards to relationships, or actually a career. There's a lot of this indirect long COVID consequences. So I think all the services around are very obviously vital and important. So I think from this, what we are planning to do is do another push on long COVID. Collectively with the other South West London Health Watchers, we are going to present the data and the insights to the South West London CCG board. And obviously we'd like to have some of the conversations locally, and we would like to obviously gather some more data to obviously just to reinforce, to add, and as these services become more apparent and people become more aware, then obviously hopefully some of the feedback will be in respect of those services too, because obviously I think as we all know, patient voice should be going alongside and parallel with any service, because these services are evolving, gaps are being flagged up, so we just need to kind of come together to look at what we can do for the best for that person that lives within the community of Merton.
Thank you, Beck, and thank you, Campbell, for presenting. We're now going to go into the discussion, so I'll hand back to Councillor Lanning, and there's a few questions to kind of steer the discussion in that way. So I'll leave it, hand back to Councillor Lanning.
Thank you, Barry, and thank you also to Campbell and to Beck for presenting. Just before we do actually run through sort of some of these discussion questions, did anyone have any questions on either of the presentations at all? I'm just running through the side to see if I can see. I can't see anyone, so if there is anyone, do just shout out. But in terms of the discussion, I wondered if I could kick off quickly with just a question to Campbell in terms of how people do access the service. I think in the patient pathway that you presented, it suggested that referrals tend to come from primary or secondary care, but I just wondered whether there's anywhere else in the community that can link in terms of referring up to the service.
So the referrals at the moment are coming from primary care, secondary care, and other medical services within South West London. The reason being is, as a part of that pre-referral investigations that are required, they need a range of blood tests a chest X-ray and an ECG following their long COVID. Again, we need to rule out, these are common symptoms of a lot of other medical issues, so we need to rule out that there's an alternate cause for their symptom prior referral. I think you're still on mute, Rebecca.
I am still on mute, thank you. What I was saying, which was very insightful, was I suppose over the last 18 months or so, we've heard a lot about, and I think part of the role of this group has been about how we engage wider groups of people to be able to ensure that there is this equity in terms of access. And I suppose to a degree there is a potential challenge with referral only being via primary or secondary care, while completely understanding the rationale for that. And I suppose just a question to the group around ways that we can ensure, I suppose, this sort of both the first point and the second bullet point on the screen in terms of engaging wider groups, individuals who might not present possibly at primary or secondary care, and ensuring that they are also able to access these services. Sarah.
Just come off mute. I'm not sure that it'll answer your question exactly, but I think as Campbell explained, the way we were asked to set up the service across London and nationally was to support a pathway that had that clinical safety net. So it is important to, as Campbell explained, to make sure that patients have the right medical checks before they come in. However, since setting up the service, what's been quite useful as a byproduct is exploring what resources are available to step and redirect the patients onto afterwards. So we've been doing a big piece of work with social prescribers in both Burton and Wandsworth to explore if we can make onward referrals to them, make a greater awareness of what's available through the service and what they offer, and a whole range of things. I think Campbell just sort of touched with a light touch about the things that patients can access, so we can direct them onto access. So whilst we're not able to change from a clinical safety point of view the referral route, I think if we can find a way of understanding the resources that are out there to engage with communities better, we can promote the service so that those that need to go through this route know how to clearly access it, can make it as easy as possible. But equally, there may be other services that are available in terms of self-management, the use of the app, etc., that we can share and make available to those that don't have to have gone through that medical route, or patients that have accessed the service but then may need support further along the line as well to make that easy. And we are looking at that, about making what support we can provide as a follow-up. So I think there are limitations to what we can do, but we wanted to be able to share what's available and link in with other community groups and resources to gather the best offer for these people in the community and make sure we push them in the right direction should they want to go that way.
Thank you, Sarah. And I suppose there's a role for this forum as well, and for us individually, to be able to take this message out and ensure that we can raise awareness of the services provided and take that out to the community as well. So any materials that you're also able to share with us sort of above and beyond this slide presentation, I'm sure is something that everyone in the group would be happy to circulate. Dagmar.
Hi, I first of all, if you don't mind me, Barry, would it be possible to take that slide down so we can see each other a bit better? I find that easier for the conversation. Thanks, thanks a lot. Yeah, so I am really grateful, Campbell. It was good to get the flair. I really liked as well that we're starting to understand, albeit small numbers, who is managing to turn up and who isn't. And I really took your alert quite seriously. There's hardly anybody from the deprived areas. I'm not 100% sure how you did it, whether it's postcode, but we could put heads together how we can have almost what I call an ongoing equity analysis. It's a bit of a pompous word, but that we are checking who comes through, and that we compare that with who we expect to see, and then focus and where the gaps are. And clearly, if we look at where the hit of the pandemic was hardest in Merton, it was in the east of the borough, in our more deprived areas. And those people, not surprisingly in a way, haven't quite made it through. So that for me as a subgroup is a real tangible challenge. And to think even how we frame some of this, because for me, listening and tuning into some of the patients' stories, there's shame, there's disbelief, there are some, I'm sure, cultural issues as well. Well, you're putting it on, you're slacking, all of that. It needs to be socialized appropriately, and I think we've got a lot of connections and networks of people that can probably help us with that, because we might not be the right people to have those conversations. So Barry, again, I wanted to think through, we've got the community champion network in the voluntary sector. We haven't got a Simon here, but really thinking through, where do we take even the a sort of a simple presentation to say, here we are, this is on offer. What is your sense? What do you hear from the community? And how can we make the connections into the offer? So that was one. I really think there's work for us to do. And the other one is to really drill down even more. And I was delighted that it's not just a medical model, that what matters to people. Yeah. Yes, the breathlessness is terrible, and that is quite a clinical sort of thing, but it is the relationships, it's the caring, it's the work. So there are other services out there and between health and care and the council that might help with all that other support, and how we possibly link up with your service offer and leverage. Yeah, so that while you've got them, you can say, oh, by the way, for helping you with work, there is other people as well that you can link up with. So that for me is and that we are refining what matters, because obviously this is a really dynamic situation. And I myself, what does it mean? 2,600 people, we think at the moment. I just told you that we have really high infection rates, on and on and on. So are we churning out lots of new people with long COVID? Probably, yeah. So how long will this be going on? So all of this we need to learn together, I think. And so for me, it's not anything static. It's something that I think we should really sort of evolve together. And I would be interested to hear primary care's take on it, because you obviously get a lot of the initial people presenting, I guess, to you.
Thanks, Dagmar. I think it's a really challenging situation. I mean, I work in a deprived practice, and actually I'm not seeing many patients. We are proactively contacting people, we're texting, we're sending letters, but they're not coming forward. So we know that we need a very different approach to the current sort of traditional approach within primary care, probably similar to the vaccination program. So really, we'd really appreciate your insights, your help and support around how we do reach out to those communities. I think from a CLCH perspective, I think we're really open to building those links. Obviously, this is a new condition. It's, as you say, it's an evolving, emerging situation where our understanding is changing over time as well, which is why we have been cautious in terms of how we accept referrals into the service. And that will also develop as we learn more about the condition. And perhaps we can then also start to develop other referral pathways in. But, these things take time. Patients are really concerned and worried. And the most common question I get is, have I got this for life, doctor? What are the long-term consequences? And we don't know. And they do feel ashamed to talk about some of the more personal issues in terms of the impact on their personal life, their work, their jobs. And those are the things that the CLCH service really tease out, because they spend so much time with the patients, which I think is really valued. So I completely agree. It definitely needs a joined up approach, and we would really appreciate the opportunity to sort of engage and connect with communities in Merton around this.
Thank you, Sai and Dagmar. I see Una has a question.
Thank you, and again, thank you for those presentations, because I think they were excellent. It struck me, I mean, I think Dagmar's mentioned some of the things that were striking me as I was listening. But clearly, yes, the east of the borough was hit the hardest early on. So it was, yeah, I think we're missing some people there. And with that in mind, I mean, I was also fascinated by the, how long these symptoms last and that sort of thing. But is it possible to get these symptoms for post-COVID a bit later on? Because I think I've seen some of this in my own family. And I'm just wondering whether that's something that people can, so in other words, people might think they've recovered, but have they really recovered? And is this virus still there? And I guess that was elucidated just now, as to a possibility, and it's an extra worry for people, quite clearly. Community champions, I think, has been really useful, and I guess this is some more work that they could take on into communities to try to make sure that people are picked up. Because coming back to whether it's something which you're living with, you may not realise, say 6 months' time, when you get maybe some bad headaches or whatever sort of things that people can develop that are new, if you like, or it feels new to them, but maybe it isn't. Maybe they had COVID not quite so severely and or at the time. So I think it is how do we pick up these people, and how do we make sure, particularly, that those in the more deprived parts of our borough are well supported and looked after. So thank you.
Thank you, Una. I don't know, Vasa, did you want to come back on any of that?
I think it's a very important question to which we don't know the answer yet, because this is not the only virus which has got a consequence of fatigue or palpitation, or when we talk about hepatitis, even a simple concept of hepatitis, we narrow it down to hepatitis viruses, but we now know there are other viruses which are not called hepatic viruses. The viruses which cause chest infections do have liver consequences in some patients. We know that. So in a way, this is really an open arena for us to learn as we honestly go along, and then we'll be able to answer the question. People who get Lyme's disease can get fatigue. People who get any virus can get a fatigue consequence to that. The chronic fatigue syndrome is a classic example of that. So I think in the end, when this, Dagmar, am I right to say when this becomes endemic, or is it already endemic? When we call it out and say this is now endemic, we will one day, I think, we'll go on to pool all our resources into dealing with the consequence of fatigue or low mood or aches and pains or whatever it may be following any virus. Because what we will realize in the end is that we can't have a discriminatory offer, that if you are fatigued by COVID, you get this. If you're fatigued by Lyme's, you get that. And if you're fatigued by something else, an unknown, unnamed virus, you get the other offer. I think that will be untenable, and I think it will be unnecessary. So I think in the end, we are going to learn to live with this disease, and then we'll be talking about long COVID, chronic fatigue syndrome, post Borrelia, Lyme's disease, fatigue. We'll learn to manage all of them, because there's a lot of generality about how we deal with them in one sense. And certain of these things will give you more cardiac consequences, certain things will give you more neurology, or certain things will give you more muscular, but we learn as we go along. But we also have to remember that if someone has recovered, we mustn't go and make them feel ill. So we really have to have a fine balance. Britain needs the workforce, so we need to go out to people and allow them to verbalize their symptoms, but we mustn't tap somebody on the shoulder who's hard at work, especially in my surgery if they are, not to tell them to sign up to Campbell's Brilliant Clinic.
Okay, thank you.
Thank you, Vasa. Could I take John and then Sai?
Thank you, Rebecca. Very good point, Vasa. We don't want to over-label people, and the label defines the illness. My name is John Rochford. I'm clinical director for Wandsworth CLSH, so size counterpart. And we all set up this service together across Merton and Wandsworth with Campbell and Sarah in a quite innovative way, like Campbell described, where therapy-led and medically supported. So much so NHSE copied us, and we become a vanguard protecting secondary care from the excess work that they can't take on at the moment and have to concentrate on their normal services. So we're very proud of it. Also, it's successful in the sense of the amount of referrals we're getting. We are one of the highest referrers in Southwest London, and we're currently getting our waiting list down and trying to, we're nearly at full capacity staff-wise. So we're hoping then to concentrate on our comms to help move into those deprived areas and really help engage to find out what's happening. But Una, you made a really, really good point. And I think it illustrates the difficulty of the system we're in. This is a new illness for us, and we're really having to work together with all our multidisciplinary teams to come at this illness in different ways. So if you have a relative who 6 months down the line has a new illness, and how we would come to what we've thought best if handling that is first you need to rule out, is it new or is it related to COVID? And the medical model is best at that. So, and that's where we get the tests in, that's where we get the investigations, making sure it's not an underlying illness. So for example, fatigue presentation, that can be one of a multitude of things, from the very severe to the very mild, and no one knows until they're investigated. When then they're investigated, this is the model, then we feel assured that people like Campbell can do the excellent work that they can do and focus on the post-COVID treatment. But like Vasa said, not labeling them, but working with them to say, how do we get through this together? We believe you. You will go through boom and bust cycles. There will be days you'll feel wonderful. There'll be days you'll feel absolutely dejected, which is hugely disheartening. So it's helping them through that process. And Campbell is doing excellent work, and he's pulled the team together in a phenomenal way in such a short time. We're very proud of him. So that to kind of lead from the front in this post-COVID service. So lovely to meet you all. I just wanted to give you just on that history of where it came from, but also in answer to your question, Una, why we have to be a little bit careful, at least at the start, like Sai said.
Thank you, John. Sai, did you want to come in?
John's covered what I wanted to say very eloquently, but it's really just not to assume that new symptoms are post-COVID. You should sort of seek advice about that, not just ignore it. That was really what I was going to say.
Thank you. Were there any final questions or any comments? No. It was a really helpful discussion. Thank you again. Dagmar.
Not wanting, very briefly, not wanting to prolong, but also in our humility of saying we are learning, well, having that humility with the patient as well. Yeah. And in a way, it's a really good model for working with patients, not doing things to patients. And I think it's we're all talking now about holistic care, about co-production, all the slightly jargony stuff, but because we're all really learning, and there is much more equality between the experts on the medical side and the experts on the patient side, I would be really keen to use that as a model. And because when we look through the list of support, and you think about your diet, you think about your physical activity, about your mental health, that is the sort of holistic preventative approach that we would like to see with other illnesses, and how we work with patients. So in turning it into something really exciting and positive as well, to say this is an area where we can practice an aspiration of a much more sort of holistic approach to our interaction with patients. I find that's something to aspire to, and then to evaluate, so that we have got some of the the data and evidence to say we want to roll this out to other conditions.
Thank you, Dagmar. And I think, Beth, I also missed you.
Yeah, thank you. Yeah, I mean, it was exactly kind of echoing what Dagmar said and what I touched on in the presentation. It's very important we take the community along this journey, and it is learning from what people are doing for their self-care, that we can learn from them. They might uncover different techniques, different method, different ways that we can actually learn from them. And also it's about out in the community. I mean, I've worked in the community sector for 18 years in Merton, so I do know the patch really well. And I think we need to also look at what is already out there that potentially can link well with the post-COVID service, and actually flag that up as a beacon of an activity or a service that can really help with a specific symptom, which, as Vas has touched on, can cover a whole range of other health issues, and actually look to enhance those opportunities. Really what it comes down to, again, is about information and making sure it's getting out to the community and they're aware of it, they know what's out there, and they know how to access it. And Campbell, I think your service is great, but obviously it's about managing expectation as well, because the greater you become, the more popular, the more people refer in. So we also got to ensure we don't let down the patients, that we don't want, they're waiting already for a number of procedures. We don't want to make them wait again for this. So that was all I wanted to say.
Thank you, Beck. Some really important points, I think, to close on as well. And it sounds like from the discussion that we are still learning with post-COVID, and it will be a continuing sort of learning process, and we'll bring this back. And sorry, I've also missed John. I'm missing everyone tonight.
You didn't miss me, Rebecca. I came in late. I'm so sorry. Just Dagmar made a really, really good point. We would really value your input in what the service could turn into in the future. So if you have any ideas of what it needs to be after post-COVID, given that we assume post-COVID will be finishing, how would you like it to develop into something else, if anything? And we would really value your input and support if you feel there's a need.
And I suppose just on that point and being able to keep this conversation going, obviously we will have sort of future meetings, our next meetings in December, but in the interim, in terms of being able to share insights or any thoughts that we have, what would be the best way of being able to sort of pull that information? Is that sort of centrally through us, or does anyone have any thoughts on how those kind of learnings or insights are best shared?
I think
Barry?
we can, Barry got his hand up? I was referring that we can take some of the connecting outside this meeting and the linking up between the different services. Barry, do you want to help?
Yeah, great. Thank you, Dagmar. And it's been fascinating just listening into that session. Again, those community links that we have developed and enhanced throughout the pandemic, working with those voluntary sector organisations, I will take those forward outside. Pleased that we also have a Wandsworth and Merton post-COVID steering group that's meeting tomorrow. So again, we can take this discussion, it's on the agenda tomorrow, so that we can work on those next steps on the equity audit, understanding how we can connect those holistic services to the medical services, so that we can really, but anything else from colleagues that are not connected to that steering group, send them through to myself, and happy to connect them in that way.
Thank you, Barry. And Sarah, did you also want to come in on that?
Yes, thank you, Rebecca. So something similar to what Barry was saying, but I think as we've heard, if there are several dots already that exist that we just need to join up, what are the sort of existing repositories of information or points of contact where we could share information and just use what's already there rather than having to necessarily wait to create something different. And I understand what Beck was saying. I think a lot of us have been working in the Merton area for many years, but it's still surprising how information isn't widely understood and known about what's there. So if people are able to direct us to some helpful points of contact, then we could start working on that already. But as Barry said, we can take it back to the steering group tomorrow and get some ideas about what are the next steps and what are some quick wins, perhaps.
Great, thank you, Sarah. That sounds very encouraging. So I suppose at our next meeting on the 14th of December, we'll be able to reflect on a couple of these points. But thank you all for joining this evening's meeting and for your contribution and also for your presentation. And I look forward to seeing you soon.